Okay, so good morning everyone. Today we continue our journal club presentation with Dr. Rachra. She will talk about a very important topic, in my opinion, that's the bariatric surgery, which is the weight reduction surgery. It's becoming a trend these days. Everyone is doing gastric sleeve and balloon and I don't know what. And we literally have very little information about what they are doing, how they are doing it, what should be looking for before surgery and after surgery. So I wish that we can get a lot of benefit from this presentation.
Bismillahirrahmanirrahim. My name is Ahmed D. I'm Senior Professor of Radiology. Today I'm going to present my seminar, which is on the imaging of a bariatric surgery and its complication, supervised by Dr. Ahmed D. The bariatric surgery, it's a weight loss surgery. And before starting the radiological side of the bariatric surgery and its complication and its imaging of the complication, I'd like to talk a little bit about the surgical side of the bariatric surgery. What's the bariatric surgery and its history, and which types of the bariatric surgery is present, and the most common type. I'll try to discuss it in details, and its imaging with their complication I will discuss later on in the next few slides. First, we will start with the history of the bariatric surgery. The obesity surgery, it means the weight loss surgery, it's not a new discipline. It is history at the first time of the bariatric surgery, returning back to the 1954 in the Minnesota. The procedure was a jejunal-ileal bypass. And the second time was in 1966, and the gastric bypass was introduced as a surgical procedure of a weight loss in the University of Delaware. In 1977, Griffin reported the first Roux-en-Y gastric bypass. What's the meaning of the Roux-en-Y? It means in the shape of the Y. So the gastric bypass, the Roux-en-Y gastric bypass, its history trends back to 1977. And in 1980, the surgeons with the more conservative approach, they developed the vertical banded gastroplasty. I will talk about all of them in detail in the next few slides. The procedures with the longer intestinal segment bypass were also introduced, such as the biliopancreatic diversion. It's really a major surgery done for those people which their body mass index is more than 60. So, let's know why we are doing a bariatric surgery for the obese people. Because you know that the obesity will predispose the people to the pulmonary diseases or the idiopathic intracranial hypertension, stroke, DVT, coronary heart disease, and non-alcoholic fatty liver diseases, severe pancreatitis cancer, phlebitis, and osteoarthritis, gallbladder diseases, gynecological abnormality, gout, skin problem, all these things. It means it will make the patient too prone for the comorbidity. I will talk about them later on. So that's why we have to make a solve and an important management for those people who have a morbidly obesity. So what are these treatment or the management for those people? About the options for the people who are morbidly obesity. First of all, we will try with them with the diet and exercises and behavioral change. By this way, only 10% of their body weight will be lost. So it's not a long-term losing of the body weight, as the patient may be worried about that because will be under stress. And the second type for losing the weight is the weight loss drug. The weight loss drug, a minimum sustained weight loss, okay, and the side effects of the drug will make them to stop this option. So the third part is the weight loss by the surgery. Why the weight loss surgery is preferred for the morbidly obesity people? Because 55 to 75% of their body weights will be lost. The guidelines for the treatment of the overweight and obese individuals, we are depending on the body mass index. The body mass index of less than 25% will have a health risk of a minimum value, and also risk with the comorbidity will be low. So what's the treatment for those people? Healthy eating and exercises and a lifestyle changes, that's enough for them. While the body mass index of 25 to 26.9 will have a health risk of a low level and a moderate risk with a comorbidity. And the same, like the previous one, healthy eating, exercises, and the life change will be enough for these groups of the people. While the body mass index of 27 to 29.9 will have a moderate health risk and a high risk with the comorbidity. What's the treatment for those people? Apart from the above plan, there will be a low-calorie diet should be put for them. While the body mass index of 30 to 34.9 have a high health risk and also very high risk with more comorbidity. So, what is the treatment for those people? All of the above, I mean the healthy eating, exercises, and a lifestyle change with the low-calorie diet, we will exchange it to a pharmacotherapy with a very low-calorie diet. For the people who their body mass index is 35 to 39.9, they have a very high health risk and extremely high risk with the comorbidity. Have the same way for the treatment. But those people who have a body mass index for more than 40, they have an extremely high health risk with extremely high risk with comorbidity. All of the above plus the bariatric surgery. So the bariatric surgery is chosen for the people who their body mass index is more than 40. The diet and exercises are not effective long-term in the morbidly obese patient. Why? Surgery is an accepted and effective approach. So medical comorbidity are improved in those people who are doing the bariatric surgery, and the life expectancy will be increased, and also the health care costs will be decreased. As you know, if they lose too much of their weights, they will not put too much money for their health care. A surgical risk is acceptable in comparison to the long-term obesity. So, let's know who are the surgical candidates for the bariatric surgery. Those people who have a body mass index more than 40 kilogram per meter square, or the people who have a body mass index more than 35 kilogram per meter square with a major medical complications of the obesity, or failure of the other approach of a long-term weight loss. The relative age for the bariatric surgery is in between the 18 and 55. That does not mean those who are smaller or bigger than this group of the ages, they have not to do the bariatric surgery. But this is a relative age for these people. What is the pre-operative evaluation? The pre-operative evaluations for the bariatric surgery is that we have to focus on the issue of the patient. What does that mean? For example, those patients will have a cardiorespiratory status problem with the airway problem. So we have to put our focus on this issue exactly. Or they will have a comorbidity. What's the meaning of the comorbidity? It means that you will have a hypertension, a diabetes, and also heart diseases with ischemic heart disease and obesity hypoventilation syndrome. That will make a big problem for the patient even during the surgery or after the surgery. So we have to focus on this issue. And metabolic syndrome, especially for those people who did the bariatric surgery before and they will do it another time as the failure of the previous one. So they will get a metabolic syndrome, so we have to focus on them. Results of the sleep studies. Study is very important for those people, and history of the previous surgeries. May have a big surgery done before, so you are going to do this major surgery, you have to put in your mind and focus on it. The anesthetical challenge needs for the ICU admission, because the post-operatively they need special care, so it's very important to focus on this issue. Current medication, what type of the medication these patients are taken, so we have to make a plan. A patient schedules for the repeated bariatric surgery, as I talked just right now, the repeat bariatric surgery should be screened preoperatively for a long-term metabolic and nutritional abnormality. What are the investigations should be done for those patients? I will talk about them so briefly in order not to take the time. We have to focus on the radiological side of the bariatric surgery. Fasting blood glucose, very important, and lipid profile, electrolyte, and the serum chemistry, evaluating of the renal and the hepatic function. Complete blood count is very important in this patient, and serum ferritin, vitamin B12, thyrotropin, 25 hydroxy vitamin D. The arterial blood gas is very important to be checked about them because to help for evaluation of the ventilation, as well as needs for the perioperative oxygen administration and post-operative ventilation is very important. So routine pulmonary function tests is very important. Liver function tests are not cost effective in asymptomatic obese patient. It means you can not do it, or if you do it, you have not to do it if the patients have no ability for the cost, you can not do it. Coagulation profile is very important because of the liver problem and the repeated surgery, and also Oristat. The ECG and echocardiography sleep study if suspected the obstructive sleep apnea. Sorry. What are the risks? We have two types of the risk: a major risk and also a minor risk. The death that's caused by the bariatric surgery post-operatively is only 1%. And a severe malnutrition, it means the anemia and osteomalacia, peritonitis from the leakage or the rupture at the staple sites, or the other infection, and obstruction caused by the scar tissue in the stomach or the bowel. These are the major risks. What are the minor risks? Dumping syndrome, and also diarrhea, malodorous gas production, lactose intolerance, hair loss, and may have to eventually undergo the surgical revision, speaking surgery, and pain post-surgery. So I would like to just clarify the dumping syndrome is that, for example, they will get a nausea, vomiting, abdominal pain, or sometimes they may get, example, early losing of the hair. All these things are returned back to the dumping syndrome. That's very common among the people who are doing the bariatric surgery. Concurrent and pre-operative and prophylactic medication for the patients of the bariatric surgery, and usually medication should be continued until the time of the surgery, and they are on the certain medication. So with the possible exception of the insulin and the oral hypoglycemic, this is the job of the surgeon or the medical physicians to focus on this issue. Antibiotic prophylaxis is very important for those people preoperatively to be put, and obesity itself does not increase the risk of the aspiration or acid aspiration prophylaxis, including the H2 receptor agonist, and these are returning back to the medication. Anxiolysis and the prophylaxis against the deep venous thrombosis should be addressed at a pre-medication. It's very important at this point. The DVT consideration, the morbid obesity. The morbid obesity is a major independent risk factors for the sudden death from the what? From the acute post-operative pulmonary embolism. Subcutaneous heparin, 5,000 international units, administered before surgery and are repeated every 8 to 12 hours until the patient is fully mobile and reducing the risk of the DVT. Pre-operatively, prophylactic placements of an inferior vena cava filter should be considered in those who have a venous stasis disease or body mass index more than 60. It means morbidly obese patient, and obstructive sleep apnea, also truncal obesity. In those patients, prefer to do the inferior vena cava filter. So, how does the surgery work? How does the surgery, bariatric surgery is working? And depending on this way of the work, we will dividing the bariatric surgery types into 3 groups. But first of all, let's know how the surgery is working. First, by the restrictive way. What's the meaning of the restrictive? It means restrict the amount of the food ingested by the patient. Decrease the appetite and hunger, and early satiety and behavioral modification with a gastric banding lab. And this, what's the type? Gastric banding lab? They're making the size of the stomach smaller, and that's making the patient to feel the satiety before eating too much. So it's very important. And what are the types that is depending on this way is the gastric banding or lab banding. I will talk about them in the next few slides. Or Roux-en-Y gastric bypass. This is the most common types of the bariatric surgery done for the patients who have a morbidly obesity. And also sleeve gastrectomy is also one of the commonest type of the surgery done for these patients. A malabsorptive limits the digestions and absorption. What does that mean? Decreasing the length of the intestine exposed to the digested food. It means that the small intestine will be cut off, in which the food are not passing through it. So by this way, they will decrease the absorption of the glucose especially. You know that the high calorie food materializes the glucose, so they will decrease the absorption of it. 25% of the fat is absorbed by this way, and also behavioral modification. The biliopancreatic diversion with a duodenal switch is another type, and it is related to the malabsorptive type. This type of the surgery is really a very big, a major surgery. This is done for those patients who have a body mass index more than 60. So this is not usually or commonly used for decreasing the weight, losing the weight, All operations can be performed open or laparoscopically. All these operations that we talked about that can be done open surgery or in laparoscopical surgery. Let's know what's the difference in between the open surgery and laparoscopical surgery. The laparoscopical one is that decreasing the post-operative pain and also early mobility, decrease the wound complication, and 2 to 3 days will stay in the hospital, returning back to the work after 1 to 3 weeks. While the open one, increasing the post-op pain and longer hospitalization would increase the wound complication. As you know, the infection, hernias, and seroma are the complications of the wound. So the laparoscopical will be preferred on the open one, but they have the same benefit with returning back to the work within 4 to 8 weeks in comparison to the laparoscopical one. It's a long time. Goal. What is the goal of our seminar on bariatric surgery? First of all, describing the surgical anatomy and the normal imaging findings for the 3 major forms of the bariatric surgery. As I talked to you before, bariatric surgery, there are many types of bariatric surgery, but the 3 major ones that's commonly used and repeatedly used in the last decades, I would like to focus on them more. And the other types, I will just talk about them briefly, not like the 3 major types. And identifying the major complication of those types of the bariatric surgery and their relevant clinical features. Discuss the imaging findings of bariatric surgery complications on the upper GI or gastrointestinal tract examination. Let us talk about, as I talked to you, that the bariatric surgery working by the restrictive way, or by the malabsorptive way, or mixing in between. So we are going to talk about the types of bariatric surgery according to the way of the working of the surgery. First of all is the restrictive procedure. What are the restrictive procedure? The vertical banded gastroplasty and also adjustable gastric banding with a sleeve gastrectomy and a gastric application, intragastric balloon or gastric balloon. These are 5 types of the restrictive procedure. The most common type is the adjustable gastric banding or the sleeve gastrectomy. I will talk about them in the next few slides. Malabsorptive procedure. The malabsorptive procedure, as I talked to you before, that is depending on cutting of a part of the small intestine, making the absorption of the fat, especially with the glucose, a little bit lower than the normal way. So what are the types of them? Is the biliopancreatic diversion, as is done for the patients who their body mass index more than 60, and also the jejunal ileal bypass. This is a very old fashion. It's done in 1955, and endoluminal sleeve. I'll talk about them briefly, but they are not the common one. The mixed procedure. The mixed procedure, gastric bypass Roux-en-Y, which have a certain abbreviation that was used commonly. If you can try to memorize it, RYGBP. This is the most common type of the bariatric surgery. Sleeve gastrectomy with a jejunal switch. That one also common, but not like a sleeve gastrectomy, and implantable gastric stimulation. I'd like, before starting the imaging of the bariatric surgery and its complication, how it appears on the radiological imaging. So let's just make a review on the normal anatomy on the CT scan. First, on the pictures that's on the right side, you will see this is a normal abdominal CT. This is the stomach. As you see, it's more anteriorly. And in this view, you will see the liver. And this is a stomach. There is no small, there's also a little bit small bowel, but it's not so prominent. So focus in this slice that the stomach, its shape will be like that, full of the contrast and also the gas. On the other side, there's also stomach. Behind there is a spleen and also liver. Going more down, this is the stomach and spleen. This one is
Spleens?
Yes, that one.
Colon.
Yeah, colon. There's no small bowel in this free section. So next slide. But here you will see that the bowel is full of the contrast. We have to focus on how are their shapes without surgery. This is the shape of the small bowel in 4 slice sections.
So oral contrast.
Yes, oral contrast filling the small bowel. Okay. Laparoscopic gastric bypass, which is also called a Roux-en-Y gastric bypass, is, as I told you, it's the commonest one and preferable one. As you see in this picture, how are you?
This one, right?
No, the other side. Yeah. The number one, you will see this is a small patch of the stomach that is separated from the large part of the stomach, which is called the extreme part of the stomach. The small pouch, that is the pouch, the restriction way of the bariatric surgery done for the patient, and then the distal, the proximal part of the small bowel will be cutted. Then the raw limbs of the jejunum will move up to anastomosis with a small pouch, and the biliopancreatic limb of the proximal jejunum will be anastomosed with the jejunal, yes, right there, in order to make a Y-shape reconstruction of the guts, as you see here. In the next few slides, I'll make it so clear.
So
mixing.
basically, they remove all this part.
Yeah.
They not remove, they isolate.
Yes, isolated
This
by the
part
staple, by the staple.
It's still in, but it's not functioning.
Yeah.
And they keep only this
It's
small
too
part.
contracted.
And they cut the jejunum, fuse it here, or suture it here, and the distal limb is sutured here.
Yeah.
So to make it in Y shape.
Yes.
That's what
Next
was
slides will clarify more about the way of the surgery. As you see here, the first step, they will cut a small pouch at the fundus, just right, yeah. Next slide. They will cut the proximal part of the jejunum, as is shown here in this picture. Then, the raw limbs of the jejunum will anastomose with the small pouch, and the biliopancreatic limbs will be anastomosed side by side to the jejunum, right here. So if you note here that there is a Y-shaped reconstructions of the gut, that's why it's called a Roux-en-Y bypass. This is another picture. I put too much picture in order to imagine and memorize.
They unite this with the rest of the bowel to keep the pancreatic and biliary secretions functioning.
Yes. Has long-term success and it's a greater weight loss, malabsorption and restrictive. As I told you before, this is the mixing type. A stomach divided into small gastric pouch, and which is called a restrictive effect, which has a restrictive effect, and larger excluded stomach, as it's shown here. So in imaging, we have to focus on a point that the contrast not go to the excluded part. If you see that the contrast go into the excluded part, that means that there is a connection in between, and the weight gain will recur again. So this is not a good point. This is our job to focus about it. Jejunum divided into two parts. The raw efferent limb, the anastomose, to the gastric pouch proximally, and the jejunal-stomy distally. And biliopancreatic limb, as I told you, will be anastomosed to the jejunal-stomy. This is another picture. I'm just putting all the pictures in order to put and memorize it easily. How does the Roux-en-Y work? As I told you before, surgical factors, restriction of the meal size, dumping syndrome, cell malabsorption and decreased appetite, patient factor, caloric intake, and the caloric expenditure. Advantage of the Roux-en-Y gastric bypass surgery, most commonly performed and most reliable operations for a long-term weight loss. And long-term weight loss average 60 to 75% of their weight will be lost by the surgery. And malnutrition is unusual in this type. A substantial improvement and resolution in many comorbid obesity conditions. Laparoscopic gastric bypass complications, what are there? These are surgical complications. I will talk about the radiological complication, not reversible this type. And also mortality rate is about 0.5 to 1% in this type. Perioperative complication is 5 to 10%. Stricture of the gastrojejunal is only 10%. The long-term risk of the protein and vitamin deficiency and the marginal ulcerations of the gastrojejunal anastomosis, long-term risk of the intestinal obstruction will be 2%. The assessment of the Roux-en-Y. This is our job. We have to focus about it. First, in a scout view, the gastric, we have to look to the gastric pouch and gastrojejunal anastomosis with the raw limb and the jejunal anastomosis. We have to look for what? So if there is any leak, if there's any stricture, if there's any obstruction, if there's any ulcer, exclude the stomach and the biliopancreatic limb will evaluate it. Okay? So exclude the stomach is very important to focus about it. I will talk about them later on in the next few slides. To where is it and what's happening if have any problem. So for the CT or a contrast right before the exam, And contrast in a gastric pouch is important. Raw limbs to the jejunal anastomosis. You have to focus in this part also. Exclude the stomach collapsed and not opacified. It's very important, this point, because it's not functioning part of the stomach, should be collapsed and should not be opacified. If it's opacified, that means there is a leakage of the contrast into this part, and this means failure of the operation. Leak, stricture, obstruction, ischemia, collections, all these we have to take in consideration. Here, this shape, this is a barium meal and follow through, showing the small gastric pouch as is shown here.
And just note, we can never use barium in these cases.
Sorry, not barium, the water soluble. Yes, sir. I'm sorry. The water soluble. This is a small gastric pouch, and this is raw limbs. And this one is the small blind afferent limb, the SA, gastrojejunal anastomosis background, and surgical drainage. And this is the surgical drainage, the white one. Yeah. This post-operatively, I think they will do it after operation within a few days. Roux-en-Y normal anatomy. This is the also gastric pouch, and this is, yes, the jejunum, and that's filled with it, and this parts of the this is called a biliopancreatic limb of the that anastomosis with the jejunum filled with the gas. Yes, this is and the other side, which is the left side. Yes, no, this one is the excluded stomach. That is yes, that's collapsed. Where is it exactly? As it's shown here, just anterior to the spleen, and the small pouch anterior to the excluded stomach, with the jejunal loops, as it's shown here, is filled with the contrast. So we have to focus on this point. This is a normal post-surgical imaging of the Roux-en-Y bypass. This is a detail if you want to read about it more. The same explanation is also the same if you want to memorize it. What are the complications of the Roux-en-Y bypass surgery? First, leak. Second, strictures, marginal ulcer, jejunal ischemia, small bowel obstruction, recurrent weight loss. Leak. Up to 5% of the patient will develop the leak, and third of them had the gastrojejunal anastomosis. It means at the side of the anastomosis between the small pouch and the raw limbs of the jejunum. Usually, less than 10 days post-operatively, this complication will be occur. And abscess peritonitis sepsis, if it's occur, will be followed by this complication. H2O soluble upper GIT per oral. What does that mean?
Per oral. The per oral digestion after 1 to 2 days.
Yes.
If the patient eats too fast after 1 or 2 days,
yes, not chewing gum. Yes, they will develop this types of the problem. Percutaneous drainage and the antibiotic advise this surgery. First, they will try with this types of the complication, not operation, urgent operation. Antibiotic.
So see, this is the pouch, the gastric pouch, and this is the anastomosis. And here,
the leak.
The contrast is leaking everywhere. And on the CT scan, you can see this is here
outside of the jejunum.
The jejunum on the stomach anastomosis, and
here
oral contrast surrounding the spleen.
Yeah.
It's leaking from here.
These are the detailed explanation of these two pictures. Anastomotic stricture is very important. These types of the complication. A transient edema and the spasm post-operatively may occur. the 4 weeks post-operation types of the complication occur. 3 to 9% of the patient will develop this type of the complication, usually at the gastrojejunal anastomosis. The same like the previous complication will be occurring this site. Scarring vice the chronic ischemia.
Either due to scarring
Yes,
versus
or
chronic ischemia.
An endoscopical dilatation is done for these
Yeah,
types
go
of,
here and dilate
for these types of the
anastomosis.
complication. These are the detail for the. Hey, the marginal ulcer also at the gastrojejunal anastomosis will be occur. 3 to 13% of the patient will develop this type of the complication, and chronic exposure of the gastric acids to the rolling leads to these types of the complication. Epigastric pain, upper GI bleeding are seen in this patient. Surgical revision or the anti-acid drugs are usually recommended for these types of the complication. Also, surgical revision also is recommended for them. This is yes.
This is the pouch, right?
Yes, this is small pouch, and this is the rolling of the jejunum, and this is the ulcer.
Contrast.
Yes. This is detail about it. Jejunal ischemia. We have two types of the jejunal ischemia. First one is the acute, the second one is the chronic. What's the acute one? Pain, they will get the pain, bleeding, and also early post-operatively nausea, vomiting. Upper GI imaging, thickened speculated mucosal fold, as is shown here. Submucosal edema and hemorrhage can be seen. Yes, you see this is the lumen which is filled, and if you look into the mucosa, you will see it's thickened. And on CT, bowel wall thickening with mesenteric edema and also engorged mesenteric vessels can be seen easily on contrast CT. In a chronic one, the intractable nausea, vomiting secondary to the jejunal stricture, upper GI imaging, smooth tubular narrowing, loss of the mucosal fold. They will lose them. And this one is the acute one. Sorry, I didn't find the chronic one. Sorry. Non-healing giant ulcer. They will develop giant ulcer that's not healing more than 2.5 centimeters. That's why they are called the giant ulcer. CT, the jejunal narrowing with the bowel wall thickening can be seen. Bowel wall thickening on the mucosa, as is shown here. Small bowel obstruction. Up to 5% of the patient they will develop a small bowel obstruction, adhesion, internal hernia, abdominal wall hernia, stricture, intussusception. All these are the cause for the small bowel obstruction. There is two types of the small bowel obstruction. The first one, which is called type A, dilated raw limb, decompressed biliopancreatic limb, and excluded stomach. It means that the raw limbs are dilated, while the biliopancreatic limb and also the excluded stomach that are not functioning, they will be decompressed. But there is a bowel obstruction, because you know the sign symptom of the bowel obstruction, you will find out that there's a bowel obstruction. And type 2, dilated biliopancreatic limb and excluded stomach. It means the excluded stomach and biliopancreatic that are not functioning, they will be dilated. So this type will be type B. Closed loop, risk of the ischemia perforation is very common in this patient because the non-functioning one will be filled and their emptying is not so easy, so the perforation occur in this type. Type C, so to the jejunostomy, there will be small bowel obstruction distal to the jejunostomy, and dilated rollings and the biliopancreatic limb also. Yeah, all of them. There will be dilatation in all GIT. Here, if you see, the excluded stomach, as is shown here, it is compressed.
It's empty.
Yes, it's empty. And the jejunum in both sides with the small pouch, it's filled. This one also called small bowel obstruction because of the sign and symptoms. But sign and symptoms are indicated for the
indicating small bowel obstruction.
yeah,
Okay. Again,
yes.
here you can see the jejunum
Yes, abrupt in a few slices below this slice, you will see that there is an abrupt change in the calibers of the jejunum, so that's why it's a small bowel obstruction. Yes, and there is no gas in the distal part.
Okay,
Yes. Yeah. And this one is a type B. What's the type B? The excluded stomach, as it's shown here, and this exclusion is dilated, as it's shown here. So this is type B, small bowel, apart from the abrupt change in the caliber of the jejunum. These are...
so this should be completely collapsed. Now it's completely
distended. Yes. Recurrent weight gain. Recurrent weight gain is that due to the dehiscence of the gastric staple line. The gastric staple line is dehiscent, so if you see here in the imaging of the upper GIT, you will see that the contrast is go into the excluded stomach.
It should go like this.
Yes.
Now it's opening
So
and going to the excluded segment.
Yeah.
Here
So
is contrast instead of being here.
Yeah.
This is the pouch, right?
Yeah. This small pouch and this one excluded part, and the contrast is in the excluded part. So this is
failed surgery.
yes. Surgical revision is recommended for this patient. Another one. If you are tired, so
no, because of the time.
No.
Thank you very much. It's very impressive, and I hope we continue next week with the rest of these things.